Good evening, everyone. I'll try to share my screen. Yes. Okay, this is usually a workshop, hands-on workshop, but due to the current situation, we try to convert it into a lecture. So I try to insert some demonstrative videos. My name is WALEED ALETRABY. I'm an ICU specialist, background in anesthesia. I have nothing to disclose at the beginning because I'll be playing some videos that I claim no copyright to. So when we say airway management, all I'm concerned about is maintaining the pathway from the nostril or the mouth to the beginning of the respiratory tract, the larynx, patent. All I care about is that this pathway is open. I'm really not concerned what we are giving from outside, because whatever you're giving, if this pathway is not open, then the patient is not going to benefit. We'll go through the different procedures to maintain the pathway open, but just keep in mind that this is for a demonstration. In real life, we don't do that. We usually approach the patient directly with the golden standard. So this is the first maneuver you can do to maintain a patent airway. We have all practiced this before in BLS. This is called the jaw thrust, using your index and middle fingers on the bony angle of the lower jaw, and you are thrusting the jaw upwards. Sometimes this is enough to displace the tongue away from the posterior pharyngeal wall and opening the airway. The other maneuver using your hands only is also learned in BLS, and this is called head tilt, chin lift. Again, using your fingers on the bone of the lower jaw, you lift the chin upwards. This, as you can see, displaces the tongue. If this was the tongue compressing or obstructing the airway on the posterior pharyngeal wall, lifting the chin upwards can displace the tongue and open the airway. Just a small notice here that in the head tilt, chin lift, there is an extension of the neck, and that's why this maneuver is to be completely avoided if you have suspicion of cervical spine injury, which is the case in any trauma scenario or road traffic accident or any kind of trauma. So this maneuver is to be avoided. Now, if we are not successful with that, then we move to something very simple. We call this the oropharyngeal airway. And from the name, it goes through the mouth, oro, and it ends in the pharynx. So the oropharyngeal airways, if you hold one in your hand, are made of hard plastic. And the reason for that is that when it goes through the mouth, if the patient closes his mouth or clenches his teeth or even have seizures, he is not able to obstruct it and occlude it. And this way, the airway is maintained open. As you can see, there are different colorings, and each color denotes a certain size that fits a certain patient. There are some tables like this that tells you which color fits which patient, but we usually don't try to memorize these because we follow a very simple, rough method to see if the airway fits the patient. Just put the airway flushed with the mouth or the teeth of the patient, and its tip should end at the angle of the lower mandible. When we insert the oropharyngeal airway, this is how it should be when it is in place, with the C-shaped curvature following the anatomy. But actually, when we insert it in the opposite direction, the other way around. So we insert it with the tip going upwards until we hit the hard palate, and then we rotate as we push in. The reason for that is to avoid friction with the tongue. This is a very short clip showing you how it's done. So this is how it's being inserted. I'm not going to spend a lot of time talking in theory about indications and contraindication. All I want you to remember is the absolute contraindication of an oropharyngeal airway, which is an intact gag reflex. If your patient still has some consciousness and an intact gag reflex, don't think of the oropharyngeal airway. It will simply induce fighting, coughing, and sometimes even laryngeal spasm. So the absolute contraindication here is an intact gag reflex. There are other contraindications, but this is the absolute contraindication. If we're not successful with the oropharyngeal airway, we move to another one, which is called nasopharyngeal airway. So now you understand from the name, it's nasopharyngeal. It goes through the nose this time, and again, the tip ends in the pharynx. If you hold one of these in your hands, you will immediately notice the difference. It's made of soft rubber. You can easily bend it, deform it, and flex it. And the reason we are able to make it of soft rubber is that it goes through the nose. We are away now from the mouth. So even if the patient closes his mouth or suffers a fit or something, he's still not able to occlude the nasopharyngeal airway. And again, you notice there are different sizes. Each size fits a different patient. And again, we don't memorize any tables. There is also a method for the nasopharyngeal to help you detect the proper size. This time, you put it close to the nose, and the tip of the nasopharyngeal should end at the ear lobule. This way, you know it fits your patient. This is how a nasopharyngeal looks when it is in place. As you can see, it's going through the nose above the hard and soft palate and ends in the pharynx. So now, if the patient closes his mouth, he cannot obstruct it. Again, I will not talk about theory here, but again, remember only the absolute contraindication of a nasopharyngeal. It is actually the contraindication of anything going through the nose. Nasopharyngeal, nasogastric tube, nasal intubation. This is absolutely contraindicated if the patient has fracture base of the skull. So for the oropharyngeal, it's intact gag reflex. For the nasopharyngeal, it is fracture base of the skull. Insertion of the nasopharyngeal is quite easy. Take a look at this. I'm sorry.
Insert it into either nostril, and it's normally going to be into whichever nostril happens to be on.
So introducing the nasopharyngeal is quite easy. We just said that if the patient has an intact gag reflex, we shouldn't use an oropharyngeal. The nasopharyngeal overcomes this problem. The nasopharyngeal is very well tolerated, even by patients who are conscious. This picture, for example, is taken from a video in which this is a famous RT. He has many demonstrative videos. He inserts a nasopharyngeal for himself. This tells you how much it is tolerated by patients with intact gag reflexes, even fully conscious. If both are not successful, then we might move on to another relative of the airways. This is called the laryngeal mask airway, or for short, LMA. The laryngeal mask airway, remember, it's an airway, so it's still one of their relatives, although it looks a little bit complex. It is simply made of this elliptical shaped balloon. This balloon is the part that actually faces the larynx or masks the larynx, hence the name laryngeal mask. And when you inflate this balloon with air through this side port using a normal syringe, when this elliptical shaped balloon is inflated, it creates a seal around the entrance of the larynx. This seal is not always 100%. It is, as they call it in the book, less than perfect seal. Then we have this shaft, and at the end, your end is the universal connector, which can connect to an ambu bag, to an anesthesia machine, to a ventilator in the ICU, whatever. Once more, there are different sizes of the laryngeal mask, and each size fits a different patient. And once more, we are not going to memorize. I will tell you why we don't really need to memorize this table in a minute. Now, inserting the laryngeal mask, actually, there are several techniques to insert it. Personally, I was trained to the classical method, in which you hold the laryngeal mask as if you are holding a pen, and you insert it blindly in the mouth of the patient, pushing with your index finger backwards in order to slide it against the hard palate. And you go as far as your index finger allows you, and then you leave it, it's in place. They call it, it is seated. We'll show you a video of doing that in a moment. This is how the laryngeal mask airway looks when it is in place. As you can see, the elliptical shaped balloon is now masking the larynx, masking the entrance of the respiratory tract. And when we inflate the balloon, as you can see by the syringe, it creates the seal. But we just said that this seal is not 100%. It is not an absolute seal. So sometimes when you are giving oxygen or anesthesia, anesthetic gases, some of what you're giving goes through the esophagus. This inflates the stomach, and this might induce vomiting. And this is the absolute contraindication now for the LMA, which is a full stomach. So if you know that the patient has taken a meal within the last 6 hours, or has taken a non-transparent drink within the last 2 hours, you consider him to be full stomach, and you avoid using the laryngeal mask airway. Non-transparent drinks are like milk, mango juice, but tea, for example, is a transparent drink. So the patient could have taken it within the last 2 hours, and you still consider him empty stomach. So again, oropharyngeal airway, absolute contraindication is intact gag reflex. Nasopharyngeal is fracture base of skull. LMA is full stomach. I will show you why I told you we don't need to memorize the table of the sizes of the LMA, because it's written on each section of the ladder. The black line that you can see running up the center of the laryngeal mask is the opposite. As the black line running up to the center of the mask, the laryngeal balloon features a 50mm transparent So you see, every LMA has 3 essential informations: the body weight of the patient it suits, the volume of air you have to inject to inflate the balloon and create the seal, and lastly, the straight line on the back that when you align it with the nasal septum or the upper middle incisors, you are sure that it's midline and the balloon is facing the larynx. These information are all written on the back of any LMA. Now here's a quick clip about the insertion. So you see, when I was trained, I was being trained that when you insert an LMA, you have to keep some air in the elliptical shaped balloon. Nowadays, they don't recommend that. They recommend that the elliptical shaped balloon is completely empty, completely deflated to facilitate insertion. And then you lubricate the back of the LMA. This is the side that slides against the hard palate. And then you insert it blindly using your index to push against the hard palate. You go as far as you can, and then you leave it. It is now in place. Now you inflate the balloon with the recommended volume of air. It's quite simple technique of insertion. There are other techniques of insertion. Just let's have a look.
Place the tip of the larynx. Just behind
So you see, this is a different technique of insertion. No technique is better than the other. It depends on what technique you have been trained to use. But basically they are the same. Lubricate the back, slide it against the hard palate using your index finger, and go blindly as far as you can. It's in place. This is a special type of LMA called intubating laryngeal mask. I just put the picture so that you know what it looks like, because we're going to mention it later on. It's a laryngeal mask, but once you insert it, you can insert a tube inside it, and this tube goes into the larynx. Then you remove the laryngeal mask airway. It's used in difficult airway management. Now, you notice perhaps that using your hands, oropharyngeal, nasopharyngeal, or LMA, none of these methods actually entered the larynx. The LMA was the closest to come just facing the larynx, but no one of them actually entered the larynx. So all of them are not 100% secure. The only secure device is the device that goes inside the larynx, and this is the endotracheal tube, and that's why it's the golden standard of airway management. The endotracheal tube, this is the patient's side. It has a balloon that we call the cuff, that when you inflate it, again with air through this side port, it creates a seal inside the trachea. This is the shaft, and it also has a universal connector. Perhaps you heard many times anesthesiologists or intensivists talking about size of the tube, saying tube 7, tube 8. This number we are talking about is the internal diameter of the endotracheal tube in millimeters. So when we say a tube 8, this means the internal diameter is 8 millimeters. And it's always written on the shaft of the endotracheal tube. There are different sizes, different shapes, and even different structure. Like, for example, this one, this endotracheal tube is armored. Armored means it has a coil of metal within the shaft. This allows it to bend without being obstructed. You notice that the endotracheal tubes of pediatric sizes do not have this cuff, because when the cuff is inflated and it creates a high pressure against the trachea, in pediatric patients or infants, it causes injury and necrosis to the trachea. So pediatric sizes do not have this cuff. Now, choosing the size is not a big deal in adults. In adults, we usually, for a female, use perhaps even less than 7. I would use 6.7 to 7.5. Now, you know what these numbers are. They are the internal diameter. In a male, I would start perhaps by 7 up to an 8. It's not a big issue in adults. The question is in children and infants. You have to choose wisely because, as we said, sometimes the tube causes injury to the trachea. So the most famous formula is 1/3 of the age plus 3. So if you have a child of age of 3 years, 1/3 of that is 1 plus 3 is 4. So you choose the tube of 4. A less commonly known formula is 1/4 of the age plus 4. Sometimes you use that. For example, a child of 4 years old, 1/4 is 1 plus 4 is 5. So, but this is the most known or commonly used formula, 1/3 of the age plus 3. However, there's something more important than actual only the numbers. It is why you are intubating the patient, the purpose of the tube. For example, in the OR, an anesthesiologist intubating knows that he's going to intubate for the duration of the surgery, 1 or 2 hours, and then he's going to extubate the patient. So he's looking for a tube that fits the patient, but still the smallest size possible, so as to decrease the irritation and injury perhaps to the trachea. In the ICU, we think differently. When we intubate, we know that this tube is going to stay for a few days, maybe a week. So we are looking for the largest suitable tube size. And this is in order to decrease possibility of being obstructed by dry secretions, to facilitate suctioning, and to avoid having peak airway pressure alarms on the ventilator. So your choice of a size depends actually on why you are intubating the patient. This is how an endotracheal tube looks in place. It's going through the mouth. It enters the larynx. That's why it's the golden standard. And once the cuff is inflated, it creates a seal. Now, nothing from outside can enter beside the tube. Suppose the patient vomits or there is bleeding or even just the secretions. And the air you are giving through the tube cannot escape outside. And actually, if you are passing by a patient in the ICU and he has a defective cuff, you can immediately spot that just by the sound, because the air will be escaping through the trachea out through the mouth. As it passes through saliva and secretions and creates a very distinctive sound of air going through water. It sounds something like this. And we immediately, once we hear the sound, we recognize that there is a leak, and the first thing you check is the cuff of the tube. Now, the only problem of inserting a tube into the larynx, this is how the larynx looks like. These are the vocal cords. The space between them is the glottic aperture, and beyond that you can see the trachea. Now, the only problem is that there is no direct line of vision between your eyes and the vocal cords. So you have to use another instrument to show you the larynx, for you to be able to see the larynx and to get this view so that you can insert the tube in. And this instrument is what we call the laryngoscope. Now, laryngoscopes come in different models and shapes and sizes, but basically there are two main types of laryngoscopes. The one with curved blades, and this is called Macintosh, and the one with straight blades, and this is called Miller. Now, we don't have Miller in our adult ICU. It's most commonly used in pediatrics. So the most commonly you will see is the Macintosh. But there's a very important difference in the way you use them. With a curved blade, with the Macintosh, you have to place the blade in the proper position. And the proper position is exactly this point. Anatomically, this point is called the vallicula. It is the common base of the tongue. This is the tongue here, and the epiglottis. So the vallicula is the point of meeting of the tongue and the epiglottis in order to raise the epiglottis upwards to reveal what's beneath it, which is the vocal cords, as you can see. Why placing the blade above the epiglottis allows you to raise it? It's because of a small ligament here, as you can see, called the hyoepiglottic ligament. It's between the epiglottis and the hyoid bone. So once you press with the tip of the blade on that ligament, the epiglottis lifts upward. You know, just like moving a marionette. When you want to move the marionette, you just pull the string. So this is the same way. You are pulling the string here, which is the hyoepiglottic ligament, by placing the blade in the vallicula. Then the classic laryngoscope got developed. They changed the light bulb with the camera, and the camera displays on a monitor, and this is called a glidoscope. And then there is the video-assisted laryngoscope. It's also using a camera, but the camera displays on a small monitor on top of the handle. But basically, they follow the same principle. You have a curved blade and you have the handle. So I'm going to show you an animation, actually, of how to use the glidoscope to intubate.
Video laryngoscope, designed for first-pass success. A four-step technique to glidoscope video laryngoscopy combines direct vision of the patient with views on the glidoscope video monitor. Start by looking in the mouth to introduce the laryngoscope. At the screen to obtain the best live view. Back in the mouth to introduce the view. And finally, at the screen to intubate. Begin step 1 with direct vision, looking directly into the patient's mouth. The patient is appropriately positioned and with the glidoscope video laryngoscope in left hand. Introduce the glidoscope into the midline of the larynx. Gently advance the glidoscope until the tip of the laryngoscope is past the posterior portion of the tongue. Conventional laryngoscopy. The glidoscope video laryngoscope is introduced midline. No lateral displacement of the tongue is required. Step 2 is performed while viewing the video monitor the entire time. With the glidoscope inserted, look to the monitor to identify the epiglottis. Then manipulate the scope to obtain the best live view. The graph is optimized by a combination of advancing and withdrawing the laryngoscope slightly, while increasing the tilt to see the device in the molecular or on the posterior surface of the epiglottis to obtain the best live view. When the glidoscope video laryngoscope is appropriately positioned, the glide aperture is centered in the upper third of the video display. This optimal view in the display is achieved using minimal force, only 2 to 3 hands. This provides a wider view and more working space for intubation, while the camera position further reduces the effect on the view from air and secretions in the area. The video image in the mouth is the glidoscope video laryngoscope typically is primarily when the non-operating tube view. The user may be tempted to immediately insert the endotracheal tube to try to navigate through the glide aperture while continuously looking at the video screen. However, in step 3, it is very important that you look directly at the patient's open mouth and not at the video monitor, watching the passage of the endotracheal tube to avoid potential injury to the tonsils or self-ground. The endotracheal tube, which in this case is shaped by an upright rigid skylight to outline the angle of the glidoscope video laryngoscope, is inserted under direct vision until the distal tip of the tube is directly in the distal tip of the laryngoscope. This relationship is quickly and easily achieved, and only then should you return to look at the video monitor. In step 4, focus on the video monitor as you advance the endotracheal tube. Returning your eyes to the video monitor gives you a view of the glide aperture, and near it, the tip of the endotracheal tube. Sometimes a slight withdrawal of the glidoscope is required to reduce the flow and allow the glidus to dry. The tube is then advised by gradually withdrawing the style 5 centimeters as you do Our insertion step on the video monitor allows you to quickly and gently outline to redirect as needed. To review, the 4 steps to successful GlideScope video endoscopy are: in the mouth to introduce the radioscope, at the screen to obtain the best live view, in the mouth to introduce the endotracheal tube, and at the screen to intubate.
So these are the steps you actually follow to intubate. So mouth, screen, mouth, screen. I will show you another video that walks you through the actual landmarks that you visualize while inserting the glidoscope until you are able to visualize the vocal cords and the glottis.
What's the GlideScope inside the patient? There's the uvula, we also arches. We find out there's a pharynx. This is the posterior wall of the pharynx. One, four, that's the top. So the deeper, that's the tip. That's the glass. That's the here's the structures of the and then
So I hope you noticed the importance of the proper placement of the handle in the vallicula. If it's in the vallicula, then you don't see the tongue anymore, but you can see the epiglottis because it's below the blade. And the other thing, I hope you notice the importance of a proper size chosen, because you see that the tube, as it goes in, it has some friction or rubbing against the vocal cords. So if it's too large, it might later on cause edema of the larynx and the vocal cords. This is a fiber-optic laryngoscope. It's used in difficult airway management. I think it's beyond the scope of this talk. But now I want to go through very quickly the algorithm of airway management in a COVID patient, since we are in the COVID patient era. Now, the most important thing in airway management of a COVID patient is planning, is having a well plan before starting the management of the airway. And the reason for that is that you want to minimize the duration you spend managing the airway, because this way you decrease your exposure and the risk of getting the infection. So it has to be very well planned. And that's why, for example, in KSMC, we developed our own protocol. We developed our own team of airway management for COVID patients. As you notice, the algorithm starts with talking about rapid sequence intubation and then having a very good plan. So we must know who are the people in the team. They must have a checklist of all the items they need or they might need during the airway management. Everything must be prepared. The personnel themselves must be very well protected using the proper PPE. You must prepare your patient as well with pre-oxygenation. And I want to remind you here again, someone has posted on Twitter, I think, there is no emergency in a pandemic. What he meant by that is that if you have a patient who is crashing and needs immediate intubation, there is no need for heroic actions. Don't say, I will jump immediately inside the room to intubate the patient. No, first protect yourself. First put on your proper PPE before approaching the patient. There's no point trying to intubate the patient as an emergency without being protected, and you yourself and your team catch the infection and then you spread it, then you have actually caused more damage. And that's why different hospitals and different authorities have developed like the team for the airway management. We in KSMC have a team similar, very similar to the one I'm going to show you now. So as you saw, it's a 3-member team. Just like Dr. Saima told us, it is recommended that the most experienced airway manager, preferably an intensivist or an anesthesiologist, is the one who handles the airway management. And this is again in order to minimize the duration and minimize the aerosol generation during the procedures. Other places have different team formulation, like this team, for example. The difference here, it's almost the same. We have the most senior handling the airway, 2 assistants. One is responsible for the medications and the instruments and assists, and the other one probably for documentation. But this team also has the 4th member who is standing outside. They call him the clean member. As you can see, he's not wearing the full PPE and he's outside the room. His role is to help them if they need, for example, something that they haven't prepared or they need to call for help. He can run and get the help. The most important thing is following the checklist. Prepare everything ahead before approaching the patient. In this video, I'm not going to show it to you from the very beginning, but I want to show you the parts that are very important. They stress on the face bag or ventilation. When you have to do this for a COVID patient, it is recommended to be negative pressure. I mean, without active bagging. This is again to minimize aerosol generation. But if you must do it, the patient is desaturating, for example, then it has to be two-person. One handles the mask to fit it very fitting to the mouth and nose of the patient so that no aerosols escape, and an assistant will do the bagging. The other thing is, once you intubate the patient, do not connect the ventilator unless you have inflated the cuff, again, to minimize aerosol generation. If you are switching the patient from a ventilator to an ambu bag, for example, to transport him, or from the ventilator in the ICU to a portable, you must clamp the tube during inspiration before you disconnect. Have a look at this.
Pre-oxygenation, we are starting our SAUD is used to avoid back masking the patient for prevention of aerosolization. Here, avoiding coughing with prolonged relaxation. Successful, it is important to then reach out to the person outside the group if you are transporting an intubated patient to us, ensure that the or disconnect or reconnect or back mouth mask. We're saving our transport ventilators to response.
So these were very important tips: clamping the tube before disconnecting, inflating the cuff before connecting to the ventilator, and if you must bag mask the patient, you have to do a two-person maneuver. Another very important tip, perhaps you remember how we used to hold the mask when we were being trained in BLS. We used to call this the C and E. So this is the C, and these three fingers are having the E. Now, this is not the method to handle the mask that is recommended in COVID. What is recommended in COVID is the V way of handling the mask. This is called the V because these two thumbs will form a V shape. And this is because this part of your palm is much stronger and can have a better fit of the mask on the patient's face and nose. So always remember, the way to handle the mask in a COVID patient is the V, not the C and E. You remember the beginning of the algorithm was rapid sequence intubation. Now, rapid sequence intubation, in my opinion, is all about good planning. So everything must be prepared ahead. So you can see 4 prepares. Prepare the patient, have him in the proper position, have him well oxygenated, have him well monitored, and then prepare all the equipment you think that you are going to need during the airway management. Also be prepared to face difficulty. Have other instruments that might help you in difficult airway management, but this is a completely different algorithm. And then prepare the team. The team should be there, well protected. Each one has his proper donning, and it's even recommended that we visually check each other and comment on each other. If you see that your team mate is not doing his proper PPE, you can tell him, please do that again, please properly position your mask, and so on. And each member of the team should know his or her role. So this is mainly the rapid sequence intubation. And then we start to proceed. I don't think this is very important in the scope of this talk, but these are the medications that we usually use in rapid sequence intubation because they have a short duration to be effective, to act upon the patient. The only thing I want to stress upon is that you make sure that your patient is in anesthesia, is asleep, before you start to give him muscle relaxation, because otherwise the patient will have a very bad feeling of being paralyzed while he's still awake. The other thing is that we must make sure the patient is well relaxed. This is to avoid coughing while we are manipulating his airway. This is a time sequence of the rapid sequence intubation, and perhaps you can see there are about 10 minutes of planning before we approach the patient, before we reach point 0, when we start to intubate. But then the intubation itself should not last more than 30 to maximum 45 seconds. So we took our time planning and preparing everything, but once we started, we have to do it within seconds, within less than a minute. In rapid sequence intubation, we used to memorize the 9 Ps, which shows again about preparation, about protection of the cervical spine, that is the positioning of the head of the patient, the pre-oxygenation, the different medications we give, the intubation itself, and then verifying its position, and then post-intubation management. There's another P that is called cricoid pressure, but actually this is questionable. So let's go back now to the algorithm. Now we understand what is rapid sequence intubation, what is meant by the checklist and the team preparation. It is recommended that we intubate a COVID patient using a glidoscope, not the classic laryngoscope. This is to stay away from the airway of the patient. And then we move to plan A, which is the classical attempt of intubation. If this is successful from the very beginning, well, that's very good, and the algorithm ends here. But the question now is, what if we fail our first attempt to intubate? If this happens, then you ask yourself a very important question. I am not able to insert the tube. I failed to intubate. But can I still maintain ventilation of the patient? Can I still do it with apneic CPAP? This is without active bagging. Can I still do it with a face mask ventilation, or even a supraglottic device, such as the laryngeal mask? You ask yourself, can I still do that? If the answer is yes, you can still maintain the oxygenation, although you are not able to put a tube, then you might be slightly relaxed because you're not going to lose the patient. So if the answer is yes, you are going to move to plan B. Plan B is simply, is the situation okay for me to try one more attempt, but this time you change something. Maybe if you haven't already done that, you put a stylet in the tube, you use a larger blade, you properly position the patient. Is there enough time for me to try one more attempt? Or if you think that you have already done that and there is no time to perform another attempt, the patient is crashing, then you can move to plan C, which is called exit options. Exit options, which is you're trying to find an exit out of this situation. And how do you do that? You think of inserting a supraglottic device, the laryngeal mask airway, for example. You must for sure by now call for help and maybe get the help of someone who is more experienced. Or if this is all not successful, then you can go to what we call surgical airway, obtaining an airway through a surgical procedure, which is here, the recommended one is bougie assisted. But remember, we are slightly relaxed here on this pathway because we can still ventilate the patient. The problem is when you fail your first attempt, but you are also not able to ventilate the patient without the tube. So this is a real emergency situation. This is the situation we call cannot intubate, cannot ventilate. This is a real emergency because if this is prolonged, we're going to lose the patient. Remember, our patients in the ICU are usually very fragile. They have very limited reserves. So unless you do something very quickly, you might move into an arrest. So in this very risky situation with cannot ventilate, cannot intubate, first thing you do is call for help. You don't hesitate to call for the help or to ask for the help of someone who is more experienced. Now, it's your judgment. Do I consider an attempt with the supraglottic? Do I attempt another trial with the face mask ventilation using the two persons technique? Or there is no time for that, and then you immediately move to the bougie assisted cricothyrotomy. Now, decision making here is very important. It has to be done within seconds. Otherwise, you're going to lose the patient. I'm going to show you a video clip on how to do the bougie assisted cricothyrotomy or obtaining the surgical airway. So perhaps you noticed that the procedure is done by military personnel. This is what they are being taught in the army, because this technique is the quickest and the fastest that they can use even during battle, in the battlefield. This is opposite to another very, very closely similar method of obtaining a surgical airway, but this one uses a guide wire. I think we have enough time to show it to you. It's a very short clip. It depends on using a guide wire, just like when we insert a central line.
Dr. Waleed, 5 minutes left, please. Waleed?
Yes, Dr.
Because 5 minutes left.
This is the last thing.
Okay, thank you.
So perhaps you notice that this technique is very similar to the bougie assisted, but maybe it's a little bit longer in duration. And that's why the recommended method of surgical airway with a COVID patient, as always, we are trying to minimize the duration. So the recommended method is the bougie assisted. With that, I conclude, and I thank you very much. Always remember the A of your ABCs. That's the airway.